Imagine a disease that affects hundreds of thousands of people every year, is one of the leading causes of preventable hospital deaths, and often remains undiagnosed until it's too late. This is pulmonary embolism or PE. A pulmonary embolism occurs when a blood clots, usually originating from deep veins of the legs, travels through the bloodstream and becomes lodged in the pulmonary arteries. In severe cases, a large clot known as saddle embolus can block blood flow to both the lungs at the pulmonary artery bifurcation. The consequences can be catastrophic. Without prompt treatment, mortality can be as high as 30% because its symptoms often mimic other conditions. Pulmonary embolism has earned the same, the silent killer. In this session, we will uncover how pulmonary embolism develops, how to recognize it, and how timely diagnosis can save lives. Patient presentation. Now let's look the real world clinical scenario. Meet patient Priya Mehta, a 42-year software engineer who arrives in the emergency department with sudden severe breathlessness at rest. She also complains of right-sided chest pain, a feeling of impending doom, and swelling of her right leg for past 3 days. Looking at her history, two major risk factors immediately stand out. First, she has been using oral contraceptive pills for several years. Second, she recently completed a long flight, which increases the risk of venous stasis and clot formation. Now look at her vital signs. Her heart rate is 124 beats per minute, indicating significant tachycardia. Her blood pressure is low at 92 over 60, suggesting hemodynamic instability. Oxygen saturation is only 88% on room air, showing significant hypoxemia. Laboratory findings provide more. The D dimer is markedly elevated, indicating active clot formation and breakdown. Troponin is mildly elevated, suggesting strain on the right side of the heart. When sudden dyspnea, chest pain, tachycardia, hypoxemia, and unilateral leg swelling occurs together, pulmonary embolism should be considered immediately. This is a medical emergency where every minute counts. To understand pulmonary embolism, we first need to understand how the clot forms. This process is explained by Virchow's trait, the three major factors that promote thrombosis. The first is hypercoagulability, a state where the blood becomes more prone to clotting. Common causes include oral contraceptive pills, pregnancy, cancer, and certain infections. The second is venous stasis, which means slowed blood flow. This commonly occurs during prolonged immobility, such as long flights, bed rest, or heart failure. The third factor is endothelial injury, which refers to damage to the blood vessel lining. This can occur after surgery, trauma, or placement of intravenous catheters. Now look at Priya's case. Her older contraceptive use contributed to hypercoagulability, while her recent long haul flight caused venous stasis. Together, these factors created the perfect environment for a deep vein thrombosis or DVT to develop in veins of her leg. Once formed, a piece of this clot can break away, travel through the venous circulation, and eventually lodge in the pulmonary arteries, causing a pulmonary embolism. This combination of risk factors is often called the perfect storm for the clot formation. The hemodynamic death spiral. Now let's see why a pulmonary embolism can rapidly be fatal. Everything begins with the blockage. A clot lodges in the pulmonary artery, preventing blood flow to part of the lung. Although ventilation may still occur, perfusion is lost, creating a ventilation perfusion mismatch and causing rapid hypoxia. Next comes the backup. The right ventricle suddenly faces a massive increase in resistance. To push the blood past the obstruction, it must work much harder, leading to right ventricular pressure overload and dilation. Then becomes the squeeze. As the right ventricle enlarges, it pushes the interventricular septum towards the left ventricle. This reduces left ventricular filling, causing a sharp drop in the cardiac output. Finally comes the crash. Reduced cardiac output leads to severe hypotension, tissue hypoxia, and poor organ perfusion. The kidneys, brain, and other lungs begin to fail. Without urgent treatment, the patient may progress to cardiogenic shock and cardiac arrest, often presenting as pulseless electrical activity (PEA). To make matters worse, the clot triggers the release of substances like serotonin and thromboxane, causing additional pulmonary vasoconstriction and further increasing the burden of the right heart. This sequence is known as the hemodynamic death spiral of massive pulmonary embolism, a cascade that can be fatal within minutes if not recognized and treated immediately. The diagnostic minefield 5 fatal traps. Diagnosing pulmonary embolism can be challenging, and these 5 common mistakes can last lives. Trap number 1, treating the patient as asthma or COPD. PE can cause wheezing that mimics bronchospasm. Always assess risk factors before assuming a simple respiratory exacerbation. Trap number 2, rely on a normal D dimer in high risk patients. D dimer is most useful in low risk cases. In conditions like cancer, pregnancy, or after surgery, clinical judgment and imaging are far more important. Trap number 3, waiting for troponin or ECG results before starting anticoagulation. If clinical suspicion is high and there are no contraindications, heparin should be started promptly. Every minute of delays allows the clot to grow. Trap number 4, dismissing pulmonary embolism because ECG lacks the classic S1Q3T3 pattern. Remember, this finding is always present in only a minority of patients. Sinus tachycardia and signs of right heart strain are much more common clues. Trap number 5, ignoring the legs. Many pulmonary emboli originate from the DVT, deep vein thrombosis. Unilateral leg swelling combined with sudden breathlessness should always raise suspicion for DVT and PE. The key takeaway is simple. Never rely on a single test or finding. A careful history, risk assessment, and early clinical suspicion saves life in pulmonary embolism. Quantifying suspicion, the well score. Clinical suspicion alone is not enough. We need a structured way to estimate the probability of pulmonary embolism. This is where the well scores becomes essential. In Priya's case, she has clinical signs of DVT, giving 3 points. Pulmonary embolism is most likely diagnosis, adding another 3 points. Her heart rate is above 100 beats per minute, contributing to 1.5 points. This gives a total well score of 7.5. Now, how do we interpret that score? A score of 1 or less than 1 indicates low probability, where a D dimer test may be sufficient to rule out PE. A score between 2 and 6 suggests moderate probability and usually requires imaging with a CT pulmonary angiogram. But a score greater than 7, like Priya's, places the patient in the high risk category. In high risk patients, the next step is clear: urgent CT, pulmonary angiography, and immediate anticoagulation with heparin, provided there are no contraindications. The Well score transforms clinical suspicion into an evidence based advance, helping and clinicians act quickly when every minute matters. Core investigations and diagnostic yield. Once pulmonary embolism is suspected, selecting the right investigation is critical. The gold standard is CT pulmonary angiography or CTPA. It directly visualizes the clot as a filling defect within the pulmonary arteries. However, it may not be suitable for patients with contrast allergy, severe kidney injury, or pregnancy. Next is the D dimer test. An elevated D dimer suggests active clot formation and breakdown, but it is mainly useful for ruling out PE in low risk patients. In high risk patients, a normal D dimer should not delay further evaluation. ECG is especially valuable in unstable patients. Findings such as right ventricular dilation, septal flattening, and McConnell sign indicate right heart strain caused by a large pulmonary embolism. For pregnant patients or those with severe kidney dysfunction, a V by Q scan is often the preferred imaging modality. A mismatch between ventilation and perfusion strongly suggests pulmonary embolism. A lower limb Doppler ultrasound helps identify the DVT. If a DVT is confirmed in a patient with classic symptoms, treatment for PE may be given even before the CT imaging. Finally, troponin and the BNP levels are not the diagnostic but help assess the right ventricular strain and predict disease severity. The key message is simple: choose investigations based on the patient's risk level, stability, and clinical context to ensure rapid and accurate diagnosis. Radiology plays a crucial role in confirming the pulmonary embolism. On the left side is the CT pulmonary angiogram, the gold standard imaging test. The highlighted area shows a filling defect, which represents a blood clot obstructing blood flow within the pulmonary artery. This is the most definitive radiological evidence of the pulmonary embolism. On the right is a chest x ray demonstrating Hampton's hump, a wedge shaped pleural paste opacity caused by pulmonary infarction. While highly specific, it is not commonly seen and should not be relied upon to exclude the diagnosis. One of the most important exam and the clinical polls is that many patients with pulmonary embolism have a normal chest x-ray. So, if a patient presents with sudden shortness of breath, tachycardia, chest pain, and risk factors for thrombosis, do not be falsely reassured by clear lungs or imaging. Remember, a normal chest x ray does not rule out pulmonary embolism. Clinical suspicion must always guide further investigation. The key takeaway from this is simple: CTPA confirms the clot, while the chest x ray mainly helps to rule out other causes and occasionally provide supportive clues like Hampton's hump. Identifying cardiac strain, ECG, and echo. Pulmonary embolism does not just affect the lungs, it places tremendous strain on the right side of the heart. Let's start with the ECG. One classic finding is that S1Q3T3 pattern, a deep S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. However, this pattern is present in only about 20% of cases. In reality, the most common ECG finding in pulmonary embolism is much simpler: sinus tachycardia. As the clot obstructs pulmonary blood flow, the right ventricle must work harder to pump against increased resistance. This causes right ventricular pressure overload. On ECG, this overload can flatten the interventricular septum, producing the characteristic D sign where the normally round left ventricle appears D shaped. As the right ventricle enlarges, it begins to compress the left ventricle, reducing the left ventricular filling and cardiac output. A particularly important marker is that RV to LV ratio. When this ratio exceeds zero point 0.9, the risk of hemodynamic collapse and poor outcomes increases significantly. The key takeaway: ECG helps raise the suspicion, but electrocardiography reveals the true impact of pulmonary embolism on cardiac function and prognosis. The hemodynamic fork in the road. Once pulmonary embolism is confirmed, the most important question becomes: is the patient stable or unstable? This single decision determines the entire treatment strategy. On the left side are the unstable patients, those with a blood pressure below 90 milliliters of mercury or signs of shock. These patients require immediate oxygen support, and if oxygen saturation remains critically low, intubation may be necessary. To maintain the blood pressure, vasopressors such as norepinephrine are preferred. One important point: avoid aggressive fluid administration as it can worsen the right ventricular failure. Because the risk of the death is extremely high, these patients need a rapid reperfusion therapy. Usually, this systemic thrombolysis using the Alteplase or in selected cases surgical embolectomy. On the right side are hemodynamically stable patients. Management begins with oxygen supplementation and prompt anticoagulation using agents such as DOACs, low molecular weight heparin, or unfractioned heparin. Further risk assessment is then performed using echocardiography and cardiac biomarkers like troponin. If evidence of right ventricular strain is present, more advanced interventions such as catheter directed thrombolysis may be considered. In pulmonary embolism, the blood pressure guides the treatment. Stable patients receive anticoagulation, while the unstable patients require urgent life saving reperfusion therapy. Once the pulmonary embolism is diagnosed, the treatment focuses on either breaking the clot or preventing it from growing. For hemodynamically unstable patients, the treatment of choice is Alteplase, a systemic thrombolytic. It rapidly dissolves the clot and restores the blood flow. The standard dose is 100 milligrams IV over 2 hours. For immediate anticoagulation, unfractionated heparin or UFH is often used. It acts quickly and is especially useful when procedures or thrombolysis may be needed. Therapy begins when an unit of 80 units per kilogram IV bolus, followed by an 18 units per kilogram per hour infusion while monitoring the APTT. Another important option is the low molecular weight heparin, such as enoxaparin. It is commonly preferred in pregnancy and cancer associated thrombosis. The usual dose is 1 milligram per kilogram subcutaneously twice daily. For stable patients, direct oral anticoagulation have become standard therapy. A common example is rivaroxaban, giving as 15 milligrams twice daily for 21 days, followed by 20 milligrams once daily for long term treatment. One critical safety point: all anticoagulants increase the risk of bleeding. Therefore, reversal agents such as protamine and blood products like fresh frozen plasma should always be readily available while managing the major hemorrhage. Unstable patients need thrombolysis, while stable patients are primarily managed with anticoagulation to prevent further clot formation and recurrence. Practice variations, the Indian context. Pulmonary embolism is a global disease, but its presentation and management often vary based on the local healthcare realities. In the Indian context, several unique risk profiles deserve special attention. First, ID professionals and frequent travelers are increasingly at risk due to prolonged sitting during long haul flights and sedentary work patterns. Second, extended bed rest during illnesses such as dengue, typhoid, or prolonged hospitalization can significantly increase the risk of DVT and subsequent pulmonary embolism. Third, pregnancy and the postpartum period represent high risk sites. Pulmonary embolism remains one of the leading causes of preventable maternal mortality worldwide. Finally, the risk associated with oral contraceptive pill use in young women is often under recognition, making detailed history taking essential. Now let's discuss practical resource based solutions. In centers where CT pulmonary angiography is unavailable, clinicians can combine the Will score with lower limb Doppler ultrasound to support the diagnosis of DVT and PE. When direct oral anticoagulants are too expensive, effective alternatives include low molecular weight heparin or unfractionated heparin with appropriate monitoring. It is also important to discuss treatment options such as warfarin versus DOACs with patients and their families, considering the cost, monitoring requirements, and long term compliance. Most importantly, if a patient presents late or requires advanced interventions, early referral to a tertiary care center can be life saving. Even in resource limited settings, timely clinical suspicion, smart use of available investigations, and prompt treatment can dramatically improve the outcomes in pulmonary embolism. When the clot escapes, catastrophic complications. Even when the patient survive the initial pulmonary embolism, serious complications can still occur. Let's review the four major complications every clinician should know. First is the cardiac arrest due to pulseless electrical activity, that is PEA. In massive pulmonary embolism, the heart's electrical system may continue functioning, but blood can no longer circulate effectively because of the severe right ventricular failure. The monitor shows electrical activity, but there is no pulse. Pulmonary embolism is one of the most important reversible causes of PEA and should always be considered in unexplained cardiac arrest. Second is pulmonary infarction. When blood flow is completely blocked, the lung tissue beyond the obstruction becomes ischemic and may die. Patients develop sharp pleuritic chest pain, coughing of blood known as hemoptysis, and the classic radial finding called Hampton's hump. Third is the paradoxical embolism. Normally, clots from the venous system travel to the lungs. However, in patients with patent foramen ovale or PFO, the clot can bypass the lungs and enter the arterial circulation. This may result in devastating complications such as ischemic stroke, limb ischemia, or other systematic embolic events. Finally, the chronic thromboembolic pulmonary hypertension, known as CTEPH. In a small percentage of survivors, residual clot material remains in the pulmonary arteries. Over time, this causes persistent pulmonary hypertension, progressive shortness of breath, excessive intolerance, and eventual right heart failure. Symptoms may appear months after the initial embolic event. So, the key takeaway is simple. Pulmonary embolism is not only dangerous because of the acute event, it can lead to life threatening complications both immediately and long after the clot has formed. Early diagnosis and timely treatment remain the best strategies to prevent these outcomes. Racing the clock, Priya's recovery timeline. Let's follow Priya's journey from diagnosis to recovery and see how timely intervention changed the outcome. At R0, Priya arrives in the emergency department with severe breathlessness, chest pain, tachycardia, and low oxygen saturation. Her well score is calculated at 7.5, placing her in the high probability category for pulmonary embolism. Given the strong clinical suspicion, unfractioned heparin is started immediately, even before definitive imaging, to prevent further clot propagation. By R2, the CT pulmonary angiogram confirms the diagnosis, a bilateral saddle pulmonary embolism, classified as submassive PE because she remains hemodynamically stable despite significant clot burden. At R3, an ECG is performed. It reveals right ventricular dilation and the characteristic D design indicating the right heart stain. Fortunately, her blood pressure remains stable, so thrombolysis is not required. On day 1, Priya is transferred from emergency setting to the ward. Her anticoagulation is transitioned to rivaroxaban 15 milligrams twice daily, and her oral contraceptive pills are permanently discontinued to eliminate a major risk factor. By day 3, significant improvement is evident. Her oxygen saturation rises to 97% on room air. Her heart rate normalizes and she is discharged home with clear follow up instructions. At the 6-week follow up, further evaluation identifies an underlying inherited thrombophilia factor 5 lead in mutation. Because of this persistent risk factor, long term anticoagulation with rivaroxaban is recommended. Most importantly, Priya achieves a full recovery without developing chronic complications. So, in pulmonary embolism, every hour matters. Early recognition, prompt anticoagulation, appropriate risk stratification, and careful follow up can transform a potentially fatal emergency into a complete recovery story. Now, as we conclude, remember one critical message. Pulmonary embolism is a medical emergency that often hides in plain sight. It can present with breathlessness, chest pain, tachycardia, syncope, or even sudden cardiac arrest. A normal X ray does not rule it out, a normal ECG does not rule it out, and waiting for too long confirmation can cost a life. Whenever pulmonary embolism is suspected, think systematically. Assess the risk factors, calculate the well score, recognize the warning signs, and if clinical suspicion is high, start anticoagulation promptly while arranging the definitive investigations. Remember Priya's case. The difference between life and death was not a sophisticated test. It was early recognition, rapid decision making, and timely treatment. So, let this be the key takeaway from today's discussion. Act before the clot wins because every minute of delay allows the clot to grow, the right ventricle to fail, and the patient's chance of survival to fall. And with that, we come to the end of today's presentation on pulmonary embolism, Act Before the Clot Wins. I hope this session has helped you understand not only the pathophysiology and diagnosis of pulmonary embolism, but also the importance of early recognition and timely intervention in saving lives. Remember, pulmonary embolism can be a silent killer, but with a high index of suspicion. Appropriate risk stratification, and prompt management, we can significantly improve patient outcomes. Thank you for your time, attention, and enthusiasm for learning. I truly appreciate your support and dedication to become better healthcare professionals every day. If you found this presentation useful, please like, share, and subscribe for more clinically oriented and exam focused medical content. Until next time, keep learning, stay curious, and continue making a difference one patient at a time. Thank you. Take care.